Oh, we got a winner in Karen. Well done. Come see us for a shirt, Karen. And I really enjoyed your presentation this afternoon. Sorry. I'll now welcome up Rob, Kim and Mel, and we've just got this open forum discussion. So if you've got any questions for any of these guys, very knowledgeable. You've all listened to Rob and Mel's, and Kim's up with us tomorrow morning. Or tomorrow afternoon. I keep getting the times wrong. Rob was introducing himself to me as Colin at the opening party, so I think I'm going to probably pick on him a bit. Now, does anyone have a question for the group straight off the bat? Oh, look out. I'm going to give you a pass.
I'll be the passer. Yes, that's me.
Just a question around breech delivery. I know in one of your cases said that the midwife on scene was delivering this baby. Is it anywhere and is it normal practice to knowingly deliver a breech birth at home?
Not necessarily, because that falls outside of what we would call low risk or normal, but it is certainly happening a lot more often. My angry redheaded stalk midwife is actually leading the first midwifery-led breech birth clinic at Fiona Stanley Hospital. There is Breech Without Borders training, which is helping to show that when women are able to birth vaginally their breech births, upward positioning is considered to be safer because it's quicker, there is less obstructions, it is less trauma to both mother and baby. But there are definitely some different rules that you need to follow. So, and there's kind of things that you'd want to avoid. You don't want preterm babies. You don't want babies too far past term. So there are different kind of things that you need to consider if you're going to see if a woman's appropriate for even attempting a breech. Not something I'm particularly comfortable with. Sometimes if they're coming quickly, you don't have a choice, which is usually a good outcome. But certainly at Fiona Stanley at the moment, women are allowed to attempt a vaginal breech birth, and so that's within the labour and birth suite. They're not comfortable enough to have that in the birthing centre yet. So even that proximity to being close to theatre if need be. Yep.
Can I ask also if you had any experience with birth keepers? You know that's there's a trend in several countries, but in Australia most recently about birth keepers, like a holistic view on pregnancy where they don't have any or almost no checks, and if you had any experience or if you had any encounters.
Yeah, we could chat for a week about, unfortunately, the experiences with women who are choosing to free birth, which is the choice to birth completely outside of any medical model at all. We're having problems with some doulas who have no medical or clinical training at all, who are accepting money from women to guide them in their pregnancies, which essentially is, if I just said to Rob, I'm going to pay you some cash if you say yes to everything that I want, you're my doula. If you've got some talent, if you've got some talent with crystals and if you could turn the lights down and braid my hair, then you're my guy, we are having a lot of problems, and the thing is that they can be very fierce advocates when we arrive on scene as well, and we will ask if we can get moving, transferring to hospital, and they will step in front of the woman and answer for her, so we sometimes can't even communicate with the women. So we've had doulas as recent as 3 weeks ago tell our crew to stand outside and wait. And the crew said to me, yeah, it was super hot, like it was really bad. I was like, what the F are you actually doing waiting outside? For me, you may as well get advice from the cat next door because they have literally the same training. So it is a big problem, but yeah. So, and I did report a doula who used to be a registered midwife to APRA a year and a half ago. She's been involved with one baby, which was a twin who now has moderate to severe cerebral palsy, and was involved with the death of the second twin last year. Unfortunately, because we can't prove that she's involved with birthing acts, I got the email back from APRA saying that she was cleared of it. HADSCO are still investigating her, which is Health and Disability Services, and at one stage I was talking to the police because we were seeing whether or not we could go down that pathway, but as soon as coronials found that that second twin had never taken a breath, it's counted as a stillbirth. And even that detective was so horrified, she actually tried to see if we could actually upgrade it to a homicide investigation rather than a coronials. So I'm working on it. It'll be a Netflix series, and I'm definitely going to be in it because I'm going to take this bitch down. Yeah. Me? With no shoes and fight braids.
I have a kind of follow-up question to that one. We had a lady in our community who was pregnant with twins, no care at all, got to about 43 weeks pregnant.
43?
Yeah, she had
Brilliant.
one scan at about 36 weeks and known breach for both of them. What point does the ethics of her refusing any care come in? Because we were all kind of terrified to deliver these breech births because she was refusing at all to go to hospital. Luckily, someone changed her mind in the end, but what point can you step in and just, at what point does the ethics come into it?
Yeah, tragically, a baby doesn't have a right until it is born and has its first breath. And that's one of the things that we are challenged with at the moment. We had a woman that was 44 weeks and 2 days pregnant who was kind of south of Perth. She had ruptured her membranes 2 weeks earlier. She'd had 2 previous caesarean sections, one I think in Sydney and one in Brazil. And she was a very traumatised individual. And she wanted to come into the hospital because she was now birthing vaginally, and she needed some analgesia. So she came in and had some gas and air. I believe she did not let the hospital do any vaginal examinations, no listening to any fetal heart rate. They had her at the hospital. I think we dropped her off at about 8:30. She didn't birth till about 4 o'clock in the afternoon. That baby succumbed to sepsis straight away and was resuscitated, but was next transferred up to Perth, and that baby survived. So that hospital had to do exactly the same thing and sit on her and wait as well. And just recently there was a baby who passed away in another hospital that I'm aware of where the woman was exactly the same, refused to let anybody intervene. That baby was born with no heartbeat, but they were able to resus, and I think it spent maybe 2 days at the hospital before it passed away. So it's something that we're seeing more and more of, and it's also popping up in social media and things like that as well. I know there's the doula case, I think, that they've asked her to testify. I think that was in Sydney or something I literally just saw, and she's refusing. So it's something that's becoming more and more common. And I know obstetricians that are looking at leaving their profession because they're like, I just can't do this anymore. You know, if an obstetrician is liable to be sued 25 years after that baby's born because it's 7 years after that individual turns 18. So that's why their insurance is so incredibly expensive. That's 25 years for you to decide that that obstetrician cut you on the finger and you can't play piano or whatever you want to claim. Yeah.
We might just get...
pass it
I was
on.
gonna say, might just get a little intel, Kim, about what you're going to talk about tomorrow. Say if you'll give a better description than I will about what you're going to talk about, so then people can kind of dive into some questions there.
Okay, thank you. Can you all hear me? Yep. So I'm a clinical nurse consultant with the mental health team on the Gold Coast, and I'm one of the co-responders with the ambulance and with the police. And I'm also a sessional lecturer at Griffith, where I teach paramedic students around mental health when they do that unit. So the talk I've planned for tomorrow was originally planned for the National Access and Quality Conference in Sydney, where every ED in Australia is invited to attend, and it includes paramedics. So it's a little bit controversial in, I'm going to talk a little bit about ED avoidance, but I'm going to name the elephant in the room, really. So we can look at the end result of why we have delays, why we have long lengths of stays, but maybe we need to take a step back and look at prior to that. So that's why my talk's called Blocked from the First Call, because there's lots of reasons why there's blockages and increased lengths of stays, and especially from mental health. I know it's a struggle for most EDs. It's it's a passion of mine. I love working in mental health. I love trying to educate around mental health and making a difference. So I don't know if there's any mental health practitioners here. Is there any? There's not normally. But nobody specialising in mental health?
Where's Tony?
Yep, Tony's there. Yeah, Tony's there, so if I can't answer one of your questions, the tip is I just go, Tony, over to you. So I suppose if you've got any questions about mental health, or if anything that you find challenging, or you want to raise any context, then I'm happy to, help explore that and create that psychological safety, because we all have bias. That's just natural, but we need to be aware of our bias, and probably need to be aware of, least restrictive practice for mental health. Trauma-informed care is a big thing of mine. Overshadowing. I think mental health definitely, once there's a label, there's so much overshadowing that happens with our mental health patients. So I generally talk for Quentin and Dylan at most conferences, only because I think, there's a breadth of education we can deliver around mental health. I think it's, when I teach at Griffiths, I love watching the paramedic students going from their first simulation to their end, because the first one is disastrous normally. And what I try and teach is it's just about building that rapport, having that conversation. So you know what you want to get in your head from that patient, but you need to be, as I say, dipping your toes in. If you do a big bomb, it's very hard to get out of that. Yeah. So you need to be, drifting it in the right way to get the right information, and then work with the patient, because you can lead a horse to water, you can't make it drink. So there's lots of ways that we do that. So I suppose if you have any questions about mental health, then ask away.
Probably a bit controversial now, but we all know, I think in November last year, MGP, so I know that the 2713 and 2712 were removed from the Medicare rebates. These items would allow GPs to provide more mental health services in the community, and the reason is that, well, supposedly now they're being replaced with more telehealth services, like national access, like whenever you are in Australia, you can access more telehealth services. But it hasn't really, it's a bit vague how it's been conveyed to the medical community. It's not clear how this is going to work in practice. So I'm still not sure how it works. The items just disappeared, and now we have less possibilities for having the extra 20 minutes with patients in order to review their mental health care plan or to have a mental health consultation. And it just feels like everything's just regressed, right?
Yeah.
But do you know of any practical points that with this new 2026 strategy is like what is it about? I've only read about it on the media. Nothing.
Yeah.
Like any specific aspect.
And I think that's a question that I'll be asking at the national conference around the access and quality. So if I can take you back, I've been nursing for 38 years, specialising in mental health. So back in 2008, I was one of the first credentialed mental health nurses. And back then, we could see people daily if that's what was needed. It wasn't great pay. So generally, you would be having to work 2 jobs, really, to make a living. Medicare then went through a survey, it was probably 2010, 2011, which I attended each state to discuss that. There was lots of concern at the point where lots of psychologists were concerned that the mental health nurses would be taking a lot of that work away from them, which wasn't the truth. So what we're trying to say is that, under a mental health care plan, you get 6 sessions, a further 6. Having the credentialed mental health nurse can actually help that psychologist work with that patient. Because sometimes psychologists have limited sessions, they open up Pandora's box, the person doesn't have the coping strategies to manage that, so you bring in a credentialed mental health nurse who can work alongside that. And unfortunately, they still chose to shut that program down. So I've recently stopped working privately, but I was working in a private affluent neurodiversity clinic. We get 5 sessions. And really, the pay is crap. So a mental health nurse gets $56. There's no way known you can function on that, really. The 271 and the 2713, I think you were mentioning, I'm not up to date with what is happening around that, but that's a concern. Absolutely. The bulk of people who have mental health issues and see a GP is huge, and that's what I want to name the elephant in the room. We need to look at how we can get support for these people. Yeah. So sorry, I can't answer that question. I think there's lots of options, but the government need to take a step backwards rather than band-aiding all the time and looking at what needs to occur. Yeah.
I've got another mental health question, sort of about mental health patients' access
environment is loud, it's noisy, it's disruptive when they're already in this sort of heightened state usually. I know St Vinny's ED in Melbourne have something they call the Hub.
Yep.
It's like an extension of their ED essentially. It's like a secure area. It's got isolated rooms, it's got a nursing station. I don't know what the stats are, but anecdotally from patients, it's been far superior to standard ED.
Absolutely.
Is that something we're going to see rolling out to other EDs? Is that likely to be expanded on? Is this concept common? That's the only place I've seen it, but it's been great in all my experiences.
So the hubs came out of the Royal Commission. They happened in Melbourne. I can't remember the exact year. In that, there was a big overhaul. Mental health had to be treated differently. So the hubs are great, and I've heard great feedback about them too. I think other states, like in Queensland, we have our crisis stabilisation unit, which is a separate area completely to ED. There's inclusion, exclusion, and then we have expanded on that. I believe other states are trying to look at other options. But again, I'll probably hear more when I go to Sydney as to where everybody's up to. But I think people are acknowledging that EDs are not great for mental health patients. I could talk about that, like you said, around your things for weeks. Mental health patients get a really low triage score, so they wait. So most people that come to ED are distressed. As I say to our staff, they didn't come in saying, "Oh God, I'm going to piss Kim Lappin off today and make her shift shit." They're not coping with something for a reason. So when people say, "Well, give them a therapeutic wait," well, what's that achieving? We're just making the person more distressed. I mean, if we're upset and distressed, making us wait for anything is not the answer. ED environments are fast-paced. Yep, mental health's not fast-paced. And that's when I talk to the paramedic students. You're used to having emergency situation, this is what you do to manage it. Mental health's the complete opposite. Also, a lot of our mental health patients have a lot of trauma in the background. And so from trauma-informed care, EDs are not the right environment, because what we often do is we re-traumatise trauma. And that's a really sad thing to watch. Often for mental health patients, the only way to get help is the only door that's open. And unfortunately, that tends to be emergency services. Cost of living, if we look at, for everybody, I mean, we'd all feel the pinch with the cost of living. So lots of patients that need care can't access lots of options that other people would. So I think it's definitely an area that needs more, probably education, understanding, and again needs the government to really fully commit. I spoke several years ago on the ACEs study when I did a talk on trauma-informed care. So ACEs is adverse childhood events. So we know research shows that if you have 6 or more of those in childhood, and that could be something as simple as parental separation, it doesn't need to be a huge trauma, that, the impact on your health, because trauma impacts, our, hippocampus, our, amygdala, lymphatic system, like it affects everything. And we know that research showed from that study you're 2,000% more likely to attempt suicide. So we know that. There's studies out there, and this is my big, buff, but we're not doing anything about it. We talk about it, but from a political governance point of view, nobody's stepping in and saying, what can we do? We know child and adolescent mental health and they always have, the least amount of money. That's where early intervention could happen. Again, people can't access that. So there's lots of, I think, roadblocks, always has been. I don't know how we solve those easily, though. Yeah.
Singular mental health issues, so there's like a physical aspect and the mental health aspect. And I find those people in particular are the ones that get stuck. The ward don't want them, they're mental health patient. The mental health patients, mental health ward won't take them, can't have an IV line in. I'm not giving them medication. That wound care is too technical. Do you think that we need to create a space where that can merge? Because right now we're supposed to be giving this holistic care, and that is definitely not happening.
Yeah, I agree. It's definitely not happening. And when I talk about overshadowing, there's a large part. As soon as somebody hears that there's a mental health component in the background, I think that person is automatically at a deficit compared to anybody else. And I do have a case study in my talk to depict one of those, because I think ultimately people just see it as a problem. Mental health affects everybody, really. 1 in 4 will have a significant mental health condition within their life, span, and that's not counting your emotional distress or, a grief response. There's lots of different things that affect our mental health, and that also depends on our background as well. So I know that definitely we've looked at our crisis stabilisation unit, and we'll take people there with some medical compromise, but of course, yeah. Absolutely. Yeah, and they're left to wait. Yeah, and it causes more distress, more distrust on the system. When I worked in addiction many years ago, the same thing, patients would turn up to GPs. Nobody wanted to see them because they were deemed as a drug seeker or, and then we know addiction, people have lots of health issues. For an example, if you look at the, dental impact with people that use substances, especially meth, and the impact on cardiovascular system, lots of those patients aren't seen to. They're, often pushed away or seen as a drug seeker or not listened to. So I think it's definitely a problem, especially also when you see them on wards. People may go to, a ward for a medical condition and then they have a mental health condition. So that needs to be, acknowledged and worked alongside, but it's not the primary issue. And I think sometimes as soon as we hear that mental health, that becomes the primary issue and everybody forgets the other part. Does that make some sense?
Hello, I have a question for Mel. I'm a paramedic in northwest Queensland. Throughout pregnancy in some patients, syphilis and gonorrhea are quite common. I'm wondering if you've seen this in your practice, what sort of complications you're coming across and perhaps which ones I can be looking out for when I come across these patients.
I agree with you. They definitely are. And we know all of kind of infection in general is really concerning in pregnancy as well because it's definitely a large factor in preterm birth. I've seen more of that in my practice as a midwife at King Eddie's than what I have in the paramedic kind of side of it. I don't think that it comes up for us as far as a stalk call at all because I would be very surprised if any of our paramedics are kind of picking stuff up at that level. Maybe more of a kind of preterm labour or threatened preterm labour type scenario. I'm not sure. I guess really it's just going through all the normal kind of checks that we do in our antenatal care. And, I think for a lot of the women that are in our regional and remote areas, they don't access their antenatal care system because if they're pregnant and if they've had a pregnancy previously, more often than not they'll find some sort of complication that will send them out of their normal kind of environment where they'd like to birth on country and they get sent to the city. So I think there's definitely a huge issue with compliance and actually going in for your antenatal care. And we know that we're overrepresented with some of our Indigenous sisters for, gonorrhea and chlamydia and all those STIs. So I think it's creating that safe space around being able to come in for your antenatal care, and we just keep shutting down, unfortunately, our birthing centres. Yeah.
We better give Colin a go. Rob. Rob, can you tell me, I just want to kind of know about your transition, I guess, from being in the healthcare world to kind of now having this educated role in a social media world and stuff like that. Because he's basically famous on TikTok.
Okay, so a long history as an emergency nurse and a nurse educator. Transitioning from working in big tertiary referral centres, the Princess Alexandra in Brisbane and the Royal Brisbane Hospital. The opportunity came up for me while I was doing helicopter retrieval, flying in and out of really small facilities to pick up really sick patients to bring them back to the city. You know how you're always seeking for what you want to be when you grow up? Well, as a helicopter retrieval nurse, I still didn't know what I wanted to be when I grew up. But I was intrigued by these rural and remote nurses that with no resources and no team and no help and barely any electricity, what they can achieve as amazing clinicians. And I thought that's what I want to do. So I sought to do some education to become a rural and remote nurse and did, and moved our young family out to 1,000 kilometres west of Brisbane to the edge of the Strzelecki Desert in a little town called Quilpie, an opal mining town, and just fell in love with that big sky country and became a remote nurse. One of the difficulties with remote nursing is the lack of access to ongoing CPD, to education. And those nurses would constantly lament at having to make the 1,000-kilometre journey to Brisbane to go to a conference or to go to some sort of education. And I think that I'm seeing heads nod around the room. It's the same in medicine, it's the same in paramedicine. There's just nothing there for the guys that are out in the rural areas. And I was one of those nurses that too would love to have been able to keep up to date, but for the fact that it was a big commitment to have to travel to the big smoke. An organisation within Queensland Health called the Cunningham Centre that still runs out of Cairns and Brisbane, Cairns and Toowoomba in Queensland, provides education, Queensland Health education to Queensland Health nursing staff. And I was tapped on the shoulder as a trauma instructor with my background in tertiary emergency. I was tapped on the shoulder to be invited into the team to start teaching advanced life support, trauma and other rural and remote nursing skills on what was then a program to take nurse education into small facilities. So literally fly out to little places, run conferences and workshops out where you're working, not in Toowoomba or Cairns or Brisbane, but out in rural areas. And I just fell in love with doing that face-to-face teaching, being in a small workshop with 8 nurses around the tea room in some tiny little Wattsmouth along base hospital and do a suturing course or a rhythm interpretation program or whatever it is that we were teaching at the time, advanced life support in the tea room, sort of thing. Then we had a change in government. And like all, and I'm not being political, but like all changes of government, there's a red team and there's a blue team. And when the red team's in power, the blue team don't like it. And when the blue team's in power, the red team don't like it. And that's just the way politics works in this country. And so one team left, the new team were voted in, and they wanted to put their stamp on government departments. And the stamp on the government department for health was to try and find money to be able to fund Queenslanders to be able to access elective surgery sooner. So all those nanas and granddads out there that were waiting for hips and knees, they couldn't get their hips and knees for 2-3 years. They were on these hideously long waiting lists. And so the new government that were hoping to get into power put as part of their election campaign that when we get into power, we'll shorten the elective waiting lists. And of course, that was a big win for them. They got into power, and when they got into power, they decided, right, let's take all of the unnecessary departments within health and sack all of those nurses and doctors, all those people that are in non-frontline essential roles, and find some money to be able to shorten the elective waiting lists. And in my team of 7 nurse educators, we lost 4 nurses out of that cull, and I was lucky enough to retain my position. And we were told that, right, the 3 of you now, to cover all of the education for the whole of Queensland, rural areas, you have to stop doing travel, you'll have to put everything online. So an LMS, an electronic learning model was put into place by Queensland Health, and we were asked to put all of our education that we do. I was asked to put all of my education online. And I'm a face-to-face teacher. I'm not an online teacher. It didn't gel with me. I was depressed. I came home to Joe and I said, I'm going to leave this organisation. They make me want to do everything that is... I don't know how to do online. I'm an old man in this industry. I hadn't kept up with all that new computer tech stuff. So we started our own business, and we're absolutely certain that there was still a market there for nurses initially, but now nurses and paramedics to actually attend education in a face-to-face model. Do any of you agree that there's a market for that? Mm-hmm. You wouldn't be here if you didn't. Mm. We could get everything that we've been talking about over this week online, can't we? But you want to be here, you want to mingle, you want to sniff Hong Thai, you want to drink cocktails out of a bucket, you want to do all of those things, ride an elephant and get punched by a Muay Thai thing and meet a ladyboy, and you just want to do all of these. No, but you want to experience the things that a conference. I'm loving the networking. That's a big thing for me. So because of my personality, I just wanted to continue to do face-to-face education. So Joe said, all right, well, let's book a cruise boat and we'll put a whole bunch of nurses on it. And we started doing cruises with nurses. We've now done 12 cruises. There is another one coming up next year if you're interested in a cruise. Where are we going? Norway. Yeah, that's right. Yeah, so we're going to...
I'll teach on your cruise.
We'll talk. We'll talk. So where that transitioned, therefore, so we're in business. Joe and I booked a cruise ship and we put 60 people on it, and we started running conferences. Very, very similar model, I suppose, to what Dylan and Quentin are doing, except it was cruising. And then there were a few sort of face-to-face programs, sort of like this, some conferences like this. So we started doing that, but numbers are very small. Nobody knew who Rob Timmings was. So the suggestion was, well, why don't you go on social media and start putting little snippets of your education on social media, word of mouth advertising, all of that sort of thing, because I'm a tight ass and I didn't want to pay for advertising or some expensive marketing budget. So it started with Facebook, and then it sort of migrated to what's that one where the people can't read? What's it called? Instagram. It's just all photos. And then TikTok came along, and my daughter, my 23-year-old daughter, she said, don't do it, Dad, you're too old for TikTok. So I put a couple of videos up on TikTok, and ironically, one of the videos that just went crazy viral was me just demonstrating suturing on a piece of cardboard. I just demonstrated some suturing on that, and it just went nuts. And suddenly people were saying, oh, yeah, I remember you used to teach me at this particular course. Hey, are you doing any education? And it helped us to be able to fuel our business. Gave us a bit of a platform. So I love the TikTok thing because it's really simple. I can, in my break, I can do a quick 5-minute video. If it's relevant enough, it'll get likes. If it's not relevant enough, then it just sort of sits there. But it's kind of fun. I can just do that, and then we can cross-platform it across to the other, the Facebook and the Instagram and Grindr and all of those others that... Is it Grindr?
No,
not Grindr. That's not one that we do. Not okay. I meant LinkedIn. I'm kidding. So yeah, the whole social media thing just became an accident, really. I was never a social media person and then got into education. It was always the other way around. For 27 years, I've been a nurse educator. For 1 year, people have started to go, hey, are you that nurse Rob on TikTok? Yep, that's me. I love what I do. I love my teaching, and why wouldn't I bleed that over into my social life? Because I like to think that my teaching is social. It's meant to be fun. It's meant to be a bit of a laugh. It's nothing too serious, though the content is. Yeah. So thanks for that platform. And if you want to go on a cruise, have a talk to Joe. Joe will hook you up.
Another question?
Oh, yeah, no, well, I wanted to say that, so how important it is also for people who have the knowledge and expertise to go on social media, because there's so much misinformation, right, that we're fighting against.
Exactly right, yeah. So that was actually one of my key objectives, was dogmalysis, to be able to shut down that dogma. And I've made some really, really good connections with quite prominent social media nurses and doctors. Some of you might know of Dr. Mike, who's a Scottish doctor that does quite a lot of social media dogmalysis. He really attacks the wellness industry and taking people down as far as putting out misinformation online. And we've got some interesting things coming up in that social media space to be able to do a prominent healthcare professionals in social media type conference, where we're going to get some of those big player, really, really popular social media. I don't know whether you call them influencers. If you want to call them influencers, we're going to get some influencers together and actually run a conference for people to come to, so they can meet these social media influencers and hear some really good quality content. I don't want to be seen as the guy on TikTok. I want to know that you're coming to my sessions because my education's valuable to you.
I've got a question for both Kim and Mel. More like, I thought about you because of recent mental health case tragedy in 2024 at a shopping mall. I think it's quite well known in the media by now. and about handover. But because before this case, there wasn't an actual obligation of handover between the private and public sector in mental health, and it's been now they went to court. It's going to change. The law is going to change, so there's going to be more obligation of handover. Red flags, highlighting when someone goes off the medication or they are deteriorating. And I think for obstetrics, it was or it is similar between private and public sector, but there is more of an expectation of a handover when someone goes interstate or because of the high risk cases. Yes.
Yeah, I think that's an interesting one. I think we definitely need more of that handover and that collaboration. I think for mental health, a lot comes for me about definitely if I'm going to see somebody, I'd be ringing their private psychiatrist and trying to get that collaboration. I often ring our private psychiatrist and say, I'm here with your patient, just letting you know, but I've got that relationship within the state. I think it's pivotal when somebody gets referred in to try and get that information. Unfortunately, I think there's some people in private that are quite reluctant to give that information. Same thing would apply if we see somebody, for an example, in psychosis and they're on stimulant medication, and ideally that stimulant medication needs to be ceased to help with the person that's in psychosis. And then we see they go back to that private psychiatrist and that stimulant medication is continued. That's really frustrating for us. Because we know what's coming with that, you know. I think definitely all over health, I think there should be more continuity. And the hard thing I think with mental health is you also have that right to confidentiality. And definitely the case in Sydney was a bit different. But if we make it so widespread and somebody, when I talk about overshadowing, you know, has a history of depression, anxiety, and that's going to impact them, you know, they have a right to try and have some, you know, confident impact with their treating practitioner. But definitely if there's any sign of risk, then that needs to be breached. And I know in public we have to breach that. If there's a duty of care, if we think that, you know, somebody's at risk themselves or others, we definitely breach that, you know. And I think it's the way you pitch it to your patient. You know, I'll definitely say, you know, I'm not going to talk about the exact themes and everything we've discussed, but we need to share this. Does that make some sense? I just don't know how it's going to pan out, and especially between the states. So, for example, I know that Melbourne, for example, have different... Is anybody from Melbourne? So I think the mental health systems have different... their systems don't talk to one another. For one hospital... Yep.
You can't get the information related
Absolutely.
to external. And it's also very different from metro to rural
Yeah.
as well. Like there's a lot of different practices in mental health that's not standardised from metro to rural.
Yep.
And I know it annoys a lot of our mental health nurses that, because where we live is kind of a holiday destination. So you get a lot of people coming up who have mental health issues. Yeah, a lot of people, man.
Mildura. For a wedding.
Yeah.
That was a holiday.
See, whereas in Queensland...
We're going to do a Mildura.
In Queensland, our systems talk. So if there's been any context with mental health across Queensland, we can see that. We're also quite a transient population on the Gold Coast, so we get a lot of people coming up, like example schoolies or a lot of people on holidays. And again, we make it a priority to try and ring that service to get that information. And most people are really forthcoming. I'm amazed how much people give information before really checking out who you are.
It's quite hard where we are because we're obviously a border town between 3 states.
Absolutely.
So people will come over from South Australia, people come from New South, and the sharing between states is also really different.
Yeah.
So, and also in terms of mental health states, it's quite frustrating with the continuation of care. So if we go over the bridge to a New South side,
Yep. You skip.
and you need to like section a patient, it's very hard because there's also the issues with police.
Yeah.
Police can't come across, so then you're making the person wait in the back of the ambulance for 45
Yeah.
minutes for a Victorian police crew to come to meet you, and because at the moment we can't sign care and control,
Yeah.
so it causes a lot of those hiccups.
Yeah, I used to work in Victoria many years ago, and we would have the same. People just had to step across into the next state, which was very easy to do, and then your, you know, community treatment order and voluntary treatment order doesn't exist, and it was very hard to try and repatriate those people back. We have quite a good agreement up on the Gold Coast with Tweed. Often if we pick somebody up in the ambulance and we assess them, they're from that area, then we'll ring Tweed Hospital and try and get them back to their own area for treatment. But I agree there should be more communication between the states around that. I know again at lots of the national mental health conferences, there's lots of talk about that. How can we get all the states to agree? Every state has a different mental health act. It's similar, but it's different. And that's confusing for people as well. And I agree, police don't want to step over, they're across the bridge, they're across the road, out of our state area. It's difficult, and lots of people in mental health know that, how to skip the system. So, did you want to talk about that?
We're going to wrap it up.
We don't have systems that we all can access in WA either. We have DMR, which the public hospitals can access and have a look, but for example, a couple of the hospitals are a combination with Ramsay's Health of public and private. They don't put their stuff on DMR. So, the major kind of maternity hospital wouldn't be able to access the information there. They're reliant on someone faxing some information to them if they want to transfer a patient, which seems super old school. Yeah. We're quite lucky that Stalk are getting a little bit more kind of well known, that if we're on and we say, hi, this is Mel from Stalk, we've got a patient that is booked with you for these reasons. Can you tell us a little bit more about maybe why they're booked? Because they're definitely not from your catchment area. King Eddie's and some of the major hospitals will talk to us about that stuff. Yep.
Awesome. Thanks, Mel. Sorry, guys, we've got to wrap it up there. I'm sure you guys will come to the closing party tomorrow. Any further questions you want to have over a few cocktails would sound pretty good. Otherwise, if you're staying here or if you're not staying here,